Hello, everyone, and welcome to the Guthy-Jackson Charitable Foundation new series called NMOSD Grand Rounds. We really welcome everyone. We want to remind you that the Guthy-Jackson Charitable Foundation is proud to be a source of information about NMO and related conditions. The content of the following presentation is based entirely on published data and expert opinion. GJCF is not a clinical provider. It does not offer or represent diagnostic, therapeutic, or clinical care recommendation or advice on personal health. All patients and caregivers are advised to consult with their healthcare team for specific information. For NMOSD Grand Rounds, there are several overarching goals which we hope will benefit all viewers. First, the content is a practical summary of latest information on the topic. The sessions are designed to emphasize key themes and clinical pearls. We have intentionally designed the content to be inclusive of non-specialist audiences, and toward the end of the presentation will be what we call a pocket guide, which is a reference of key themes and pearls for your use. Importantly, this presentation and all of the sessions in this series enables CME credit. And the process for acquiring credit, first visit the GJCF Education Center using the QR code shown here. You will find the option to select this session and register for CME credit. Then, of course, view the session and fulfill the CME requirements. And then you will be able to receive the CME certification online. Well, it's a great pleasure to have you here. My name is Michael Yeaman. I'm an advisor to the Guthy-Jackson Charitable Foundation, and we really appreciate your time and interest in this series. I am delighted to introduce Dr. Dean Wingerchuk. He is the chair of neurology at Mayo Clinic in Scottsdale, Arizona, and a world expert on NMOSD. His topic today, diagnosis and differential diagnosis of NMOSD. Dean, please.
Michael, thanks very much for that introduction, and thanks for inviting me to be with you to do this program and share some thoughts about making a diagnosis and considering alternative diagnoses for neuromyelitis optica spectrum disorder, or NMOSD. These are disclosures which are largely due to participation in research activities related to NMOSD. My objectives today are the following. First, to review the current diagnostic criteria for NMOSD, then to recognize some red flags that point to potential diagnoses of diseases that can mimic NMOSD. We'll do that through a series of case vignettes. And finally, to identify the differential diagnosis of NMOSD, also demonstrated by the vignettes, but then summarized at the end of the presentation with some resources. Most of you likely know that NMOSD, often called NMO for short, neuromyelitis optica, is also known as de Vic disease, named after a French neurologist, Eugene de Vic, who lived in Lyon, France, in the late 1800s and early 20th century. He and a colleague described several patients near the end of the 19th century who had a disease that seemed to be a combination of acute transverse myelitis and bilateral visual impairment consistent with optic neuritis. And those two things, the spinal cord and optic nerve involvement, occurred either at the same time or very shortly after one another. They were quite severe, causing blindness and paralysis, and in most cases didn't seem to recur thus had a monophasic course. And this seemed to be a distinct and very localized disorder, distinct especially from disseminated sclerosis, or what we now call multiple sclerosis, which was also just being recognized with regards to its clinical features and natural history during the same time period. Now, fast forwarding all the way to 2005, this marked a real sea change in the field because of the identification of an antibody now called aquaportin 4 IgG, or AQP4 IgG, that targets the water channel aquaportin 4 on astrocytes. This marker is highly specific for patients who have neuromyelitis optica spectrum disorder and is typically not seen in multiple sclerosis or other competing diagnoses. So in 2006, the Mayo Clinic group put together revised criteria for the disease that expanded on the historical definition traditionally linked with Professor Devik. So in addition to transverse myelitis and optic neuritis, patients had to have 2 of 3 of the following features: a brain MRI scan that was normal or non-diagnostic for MS, a spinal cord MRI that showed a longitudinally extensive lesion, LETM, longitudinally extensive transverse myelitis lesion, which by definition is a lesion that extends contiguously for 3 or more vertebral segments. Or they were positive for the antibody that targets aquaportin 4, which at the time we called NMOIgG. One could still make the diagnosis without the antibody as long as the brain and spinal cord MRI criteria were fulfilled, but the antibody added another dimension, and especially a dimension of specificity, which was highly useful clinically and opened up a new area of research because it seemed to demonstrate quite convincingly that this disease was in fact distinct from multiple sclerosis. Around the world, after this result with the antibody was validated, people coming up with the same result that yes, this kind of patient who had optic neuritis and myelitis and a normal brain MRI and a long lesion in the cord, most of the time would have this antibody. So that was reproduced by many laboratories, but also the observation that those patients also had more to the story. So in particular, they had some additional clinical manifestations and additional MRI patterns that were not previously linked to NMO. I'll come back to these when I describe the current diagnostic criteria in more detail, but suffice it to say that many of these were signature brain MRI patterns, which now, when seen by a clinician, should trigger the possibility of NMO spectrum disorder. The other thing the antibody did was widen the clinical spectrum of the disease. So again, taking patients who had optic neuritis and myelitis and the antibody, and they sort of anchored by the antibody, groups started looking at what else do these patients have. And in addition to those brain MRI changes I mentioned, it was also recognized that some patients had multiple episodes of one or the other, either LETM or optic neuritis, but not both. But if they were positive for the antibody, they would typically convert at some point to having NMO, that is, having both optic neuritis and myelitis. So we began to recognize limited forms of the disease. In addition, in Asia, and especially in Japan, there was long held a contention that a group of patients with multiple sclerosis there had a pattern that they called opticospinal MS, others called Asian MS, and this was distinct from so-called Western MS, more typical of people seen with a Western European background. But studies showed early on that many of these patients are also positive for the antibody. And so it brought that group of patients under this umbrella of an NMO spectrum disorder. And then finally, a link between patients having optic neuritis, LETM, and systemic autoimmune disease. And as I'll discuss later, many patients who have NMO also have coexisting systemic autoimmunity. In fact, that's the rule rather than an exception. So here's a case that illustrates how far the clinical and imaging features of NMOSD have evolved over the last 20 to 25 years. This is a 29-year-old otherwise healthy man who presented after bouts of nausea and vomiting for 8 days. He then developed intractable hiccups. He had his gallbladder removed, and that didn't help. He was referred then for a neurologic evaluation after a brain MRI scan was originally interpreted as normal, but as this was being done, he presented with some new symptoms, numbness and weakness in his limbs, and within days, he was quadriparetic and had a thoracic sensory level localized to the T4 spinal segment. This is his MRI. You can see here the longitudinally extensive spindle-shaped lesion over multiple segments in the cord, the cervical cord, and how the cord looks swollen and expanded. On T1 gadolinium enhanced imaging, that lesion enhances with a ring-like pattern. This is a magnification of that here. This is quite characteristic of NMOSD, though not specific. It can be seen also in multiple sclerosis and in disorders like sarcoid. This is a good example of LETM. So in this case, this gentleman had nausea, vomiting, and hiccups, and that MRI scan I showed you of his brain that was read as normal actually showed a lesion in the dorsal medulla. I'll show that example again in a moment. He had what we call the area postrema syndrome, involvement of the so-called vomiting center in the brainstem. And later he developed longitudinally extensive transverse myelitis. He was found to be positive for the aquaporin 4 antibody in serum, and that confirmed his diagnosis as what we currently call NMO spectrum disorder with AQP4 antibodies. So what are these diagnostic criteria? Well, the diagnosis at present is stratified by the presence of the antibody. That is, you can have AQP4 IgG seropositive disease or seronegative disease. So beginning with the seropositive group, which is most common, the way I remember it is that there are 6 neuroanatomic regions, any of which can be affected by NMOSD, but 3 of which are the most common: optic nerve, resulting in optic neuritis; spinal cord, resulting in transverse myelitis, especially the longitudinally extensive variety; and the area postrema syndrome I just showed you, hiccups, nausea, and vomiting. 3 other regions are less commonly affected: other areas of the brain stem besides the dorsal medulla, the diencephalon, so the thalamus or the hypothalamus, typically accompanied by an MRI lesion that visually should make one think of NMOSD, and then other cerebral syndromes, so presentations involving confusion, encephalopathy, focal, sensory, or motor, or visual symptoms associated with MRI lesions. And I'll show you examples of all of these. The diagnosis can be made with even a single one of these events, a single event affecting a single neuroanatomic region, as long as it's associated with a positive serum antibody result. We recommend using the best available assay, which at present is a live CBA or cell-based assay. Finally, no better explanation for the clinical syndrome. This schematic shows areas of the brain, reviews areas of the brain affected by NMOSD, as well as the brain stem and the spinal cord, and some of the associated symptoms that I'll review in a moment. And as I mentioned, systemic autoimmunity, even including neurologic autoimmunity, such as myasthenia gravis, is common. There's one other manifestation of the disease that's been validated, and it's really the only report of extra CNS involvement in NMOSD with the antibody that's been reported and validated by multiple groups, and that's myositis, or involvement of skeletal muscle. So patients can develop weakness. They have elevated serum creatine kinase, or CK levels, and this can occur on its own, or it can occur in the context of a CNS attack. Aquaporin 4 is present in the muscle just as it is in the brain, and the pathology, loss of aquaporin 4, and the accompanying immunologic response seen in the muscle is strikingly similar to what's seen in the brain. So if we go through the different regions, the 6 regions start clinically, of course, optic neuritis presents with some combination of visual impairment, typically unilateral, but sometimes bilateral in this disease, accompanied by pain, usually pain with eye movement, and on examination, impaired visual acuity, a scotoma, perhaps dyschromatopsia, and a relative afferent pupillary defect. Imaging characteristically will show T2 with or without gadolinium enhancement lesions involving more than half of the optic nerve length. You might think of this as a longitudinally extensive lesion of the optic nerve. And the posterior aspect of the nerve is predominantly affected. And this is important when thinking about the differential diagnosis, as I'll mention some contrasting examples later. In particular, as shown here, the optic chiasm, which is enhancing after gadolinium administration, can be involved. And so this pattern, as shown in the image on the slide, should raise the possibility of aquaporin 4 antibody-mediated NMOSD. Here are some other examples. In the top panel, a lesion involving in the entire length of the left optic nerve. You see that in coronal cross-section in this panel, and then here's another example of involvement of the optic chiasm in panel K on the right. I've shown you an example of transverse myelitis that's longitudinally extensive already. Here's another. Central cord is affected and expanded. You can see here that the lesion is extending up towards the brain stem. Clinically, you'll imagine this will be associated with weakness, typically paraparesis or quadriparesis, depending on the localization, sensory impairment with sensory level, bowel and bladder dysfunction. Usually these events are severe, especially in the spinal cord. They can be quite destructive. Patients may require a gait aid of some type during an acute attack. Attacks are often associated with paroxysmal tonic spasms due to co-contraction of agonist and antagonist muscles, which are quite painful but respond to carbamazepine. And those ascending lesions that go up into the brainstem can cause neurogenic respiratory failure. And years ago, before we had more effective treatments for NMOSD, this was a serious cause, significant cause of mortality. About 85% of lesions reach the 3-segment threshold and are called longitudinally extensive, but some don't. I'll show you an example in a moment. Here are some other images that highlight the key features of LETM, though. In panel A, you see the localization of the lesion is central within the cord. Panel B shows what are known as BSLs, or bright spotty lesions, that are well demarcated, often multiple lesions that appear to have the same appearance as CSF and are much brighter than the typical T2 lesions seen in multiple sclerosis. Gadolinium enhancement occurs in most patients in the acute phase. The enhancement can be patchy, but about 1/3 have the ring-like expansion that I showed earlier. And panel D demonstrates one of those lesions ascending into the medulla. Here's an example of research showing that not all lesions in NMOSD are longitudinally extensive. Up to nearly 15% of patients, their first event will actually not reach that threshold. So they'll have a shorter lesion, maybe 1 to 2 segments in craniocaudal length. But as shown in the bottom panel, that lesion still tends to be centrally localized within the cord. So if one sees a patient who has a first event or an event of isolated myelitis, and it's not longitudinally extensive, brain MRI is normal, and especially if it appears central in the cord, that patient should be tested for aquaporin 4 antibodies. Interestingly, almost all patients who had subsequent episodes of myelitis did have longitudinally extensive lesions. And these patients tended to have the same features even after the first myelitis event as patients with confirmed aquaporin 4 positive NMOSD, including tonic spasms and systemic autoimmunity. The third most common region affected, perhaps in up to 25, or maybe even as much as 40% of patients in some reports, is the area postrema syndrome. So the first vignette I showed you with a young gentleman with several days of hiccups, nausea, and vomiting was quite typical. This lesion in the dorsal medulla, as shown here in panel A, in sagittal section, in the axial section, you can see the arrows pointing to the dorsal medulla as well. These are small lesions that could be overlooked, especially on the axial images, as they were in that patient. MRI was called normal. On the bottom panel here, you see panel C, a lesion in the dorsal medulla that actually enhances in a ring-like pattern. And then this is a different patient who has 2 punctate areas of enhancement in the dorsal medulla. The enhancement pattern and even the T2 signal abnormality are sometimes quite subtle and transient, so they depend on the timing of the imaging and probably also on factors such as the timing and protocol for gadolinium administration. And these lesions, unlike most other lesions in NMOSD, tend not to be destructive. They tend to be evanescent. So one needs a high level of clinical suspicion to do the MRI in the first place in these patients and recognize that it's not a GI problem, it's a neurologic problem. But this is a very characteristic pattern associated with NMOSD. The less common patterns include involvement of the brainstem outside of the dorsal medulla. So this, of course, would be accompanied by any brainstem symptoms or signs, such as vertigo, diplopia, sensory symptoms. The unifying feature here seems to be that the lesions are periependymal. So here you can see in the pons examples of lesions anteriorly and around the fourth ventricle, dorsally in the midbrain, and here around the fourth ventricle, including in the cerebellum. So quite characteristic. And you'd probably agree, atypical for multiple sclerosis. So-called diencephalic syndromes are uncommon, but again, characteristic. And here are some signature lesions. There's involvement of the thalamus in the left-hand image and the hypothalamus on the right. This can result in presentations such as encephalopathy with hypersomnolence and a narcolepsy-like syndrome, eating disorders, hyperphagia, SIADH, and other phenomena. And then finally, involvement of the brain can take many different forms. So the presentation can be focal or diffuse, can be focal with things like seizures, hemiparesis or hemisensory syndromes, or it could present with a more global encephalopathy or both. Patterns shown here include a very large confluent T2 and flare signal abnormality in the subcortical white matter with so-called cloud-like enhancement, very atypical for multiple sclerosis. In panel C here, you see the arrows demonstrating involvement of the corpus callosum, really from anterior to posterior. And what you don't see are the Dawson's fingers, the perpendicular lesions that usually occur in multiple sclerosis. Here's what you might call a longitudinally extensive lesion involving the cerebral peduncle. And the bottom three panels show flare signal abnormality and gadolinium enhancement in a periependymal pattern around the occipital horns of the lateral ventricles. So none of these is pathognomonic or specific for NMOSD, but they are lesions that have been linked to the antibody in patients who otherwise had typical features such as optic neuritis and myelitis. Now, moving on to other diagnostic modalities that are important to know, we typically would do MRI scans in patients presenting with the kinds of clinical syndromes I just reviewed. We often would do a CSF examination. In multiple sclerosis, we're looking for oligoclonal bands, or more recently, kappa-free light chains to help confirm a diagnosis. There are some features in NMOSD that can help distinguish the disorder from typical multiple sclerosis. During or near the time of an attack, about 50% of patients will have a pleocytosis that is not typically seen in MS. They'll have more cells, more than 50 cells in 20 to 30%, more than 100 in some cases. And there may even be the presence of neutrophils or eosinophils, which are virtually never seen in multiple sclerosis. In MS, a cell count of more than 50 nucleated cells is typically considered a red flag for MS, but is certainly compatible with NMOSD. Oligoclonal bands do occur in NMOSD, but at a much lower frequency than MS. So MS, we see it probably 85 to 90% of confirmed cases, but only about 20% of patients with NMOSD. And interestingly, there's new biomarkers that are coming. I mentioned in particular GFAP, which is an astrocyte protein, a fibrillary protein that is spilled into the CSF and then over into the blood when astrocytes are injured. And because the astrocyte is the target of the autoimmune response in this disease, this is a very promising marker for that type of injury and potentially could be helpful with diagnosis and monitoring in the future. Associations and mimics of NMOSD are important to be aware of. So I mentioned here first the big three events, of course, optic neuritis, myelitis, and area postrema syndrome. The other three less common ones, brainstem, diencephalon, and cerebrum. And I mentioned before the extra CNS involvement of muscle. Interestingly, other things can occur like an indirect complication of hydrocephalus. I'll show you that in a moment. And it's recognized now that in some patients, the aquaporin 4 antibody seems to have a perineoplastic association. So an association with an underlying cancer, either known or unknown. Typically, this occurs in older individuals, and they'll often have more severe and more treatment refractory disease. Here's an example of the pathology I discussed a moment ago in the muscle. So the myositis that occurs in seropositive patients can be associated with increased creatine kinase with or without weakness. And what the slide is showing here is that on muscle biopsy, these patients will have perivascular inflammation. They have immunoglobulin deposition, complement activation markers, and loss of aquaporin 4, all of which are features seen on biopsy of the CNS in affected patients. And this slide is the association of aquaporin 4 with secondary hydrocephalus or non-communicating hydrocephalus. It's uncommon, but it's thought that perhaps an immune response at the level of the choroid plexus results in CSF flow abnormalities that cause hydrocephalus. So that's not an a direct autoimmune complication, but probably an indirect one related to repeated tissue injury in that region. Now on to a second vignette. This is a 30-year-old woman who has a history of arthralgias and anemia. For 2 weeks, she's had numbness in both legs and urinary incontinence. She has painful left leg spasms lasting 30 to 40 seconds each, and now she needs bilateral assistance to walk because of her weakness. On exam, she has a moderately severe paraparesis, upgoing toes, loss of vibratory sense in her feet, and joint position sense to the knees. She also has a sensory level at T1. Her MRI scan shows a longitudinally extensive and expansile lesion here in the lower cervical and upper thoracic cord. And you can see, in fact, this extends through most of the thoracic spinal cord, quite dramatic. Her brain MRI scan was normal, and her lab studies showed that she had an anemia of chronic disease. She also had hematuria and an elevated creatinine level with multiple positive serum autoantibodies, anti-nuclear antibody, double-stranded DNA, and SSA. And originally, she was diagnosed with lupus and a complication of lupus myelitis. But in fact, after a second opinion and more extensive testing, she was found to have a positive antibody titer for aquaporin 4, 1 to 10,000, which is a significantly positive level. And ultimately, her diagnosis was felt to be NMOSD with aquaporin 4 IgG and coexisting SLE. And this is a good example of an association of NMO with other systemic autoimmunity, coexisting diseases. So I mentioned these associations before, but there are also comorbid autoimmune conditions with NMOSD. They can occur concurrently or sequentially. Systemically, there are most commonly things like thyroid disorders, hypothyroidism in particular, but Graves' disease can also occur, pernicious anemia, so B12 deficiency, and then in this patient, lupus, Sjogren's is also common. Can have neurologic associated autoimmunity such as myasthenia gravis. Often patients will have a history of myasthenia and thymectomy and then later develop NMOSD. There have also been patients who are unfortunate enough to have multiple neurologic autoimmune disorders, and the coexistence of NMOSD with NMDA receptor antibodies and associated autoimmune encephalitis is now well documented. Many patients, perhaps half, will have multiple coexisting detectable antibodies, though they don't necessarily have, at least at that point, disease expression. But it's common to find multiple antibodies such as ANA, SSA, SSB, et cetera, in these patients. So I mentioned that this systemic autoimmunity or autoantibodies frequently accompany the disease. These are the common associations I just reviewed. There was studies done to understand the relationship between NMO and these systemic autoimmune conditions. And in some very nice studies, it was shown that patients who had lupus or Sjogren's and had CNS signs, such as optic nerve or spinal cord involvement, were typically aquaporin 4 positive. But if they had lupus or Sjogren's and they didn't have any CNS involvement, they were aquaporin 4 negative. And so NMOSD seems to coexist with these disorders, and this has some implications for diagnosis and treatment, especially today. Recently, the concept of so-called lupus myelitis has been revisited. And lupus myelitis has long been considered a complication of lupus in patients with an established diagnosis or perhaps a new diagnosis who might present with a severe episode of transverse myelitis. Although that can appear to happen, perhaps due to vasculitis related to the lupus, now it's recognized that it's much more common that lupus is coexisting with either NMOSD or another competing disorder that is actually more likely to be the cause of the myelitis. Colleagues at Johns Hopkins University and elsewhere have studied this phenomenon, and this is a nice study showing the results of examination of so-called lupus myelitis in a single center. On the left here, you see data regarding the axial distribution of lesions within the spinal cord. That is, if they were central in the cord, affected the gray only or the dorsal columns only. In panel B, it shows data for the longitudinal extent of the lesion. And essentially, what this study showed is that most patients had a distinct explanation for their myelitis that was different than lupus. If they had lesions in the central cord, as seen in panel A in blue, they virtually always had NMOSD with aquaporin 4. If they had central gray only, they had MOGAD, the syndrome I'll talk about in a few moments. And you see in panel B, the patients with the long segment lesions were more likely to have aquaporin 4 or MOGAD rather than attributing their disease to lupus or another cause for that matter. So this has helped quite a bit, I think, in our understanding of how these diseases behave and altered our thinking as well about CNS involvement of lupus. Here's a third case, a 22-year-old woman, healthy, presents with a 2-day history of left visual blurring, pain with eye movement. She saw an optometrist who confirmed visual impairment in that left eye with acuity of 20/60 and some mild optic disc swelling, but was unable to make a specific diagnosis. Her symptoms resolved spontaneously after about 2 weeks. 6 weeks later, she was seen in neurology consultation, had recovered virtually to normal. Her brain MRI and optic nerve imaging were normal. OCT showed some thinning of the retinal nerve fiber layer on that left affected side. Her serum aquaporin 4 was negative, reasonable to test in this situation, but another test, MOG-IgG, was positive at a high titer 1 to 1,000, and she was diagnosed with MOGAD, myelin oligodendrocyte glycoprotein antibody-associated disease. This is a separate disease from NMOSD and multiple sclerosis, which seems to be mediated by this anti-MOG antibody. We don't know whether that's simply a diagnostic marker or its pathologic relevance, but it's emerged as a major competitor and is actually more common, especially in pediatric populations, than aquaporin 4 positive disease. But together with multiple sclerosis, MOGAD is the main competing diagnosis in the differential, especially for patients with optic neuritis or myelitis, as compared to NMOSD. And it has some different patterns as well. So I showed you earlier the pattern of chiasm involvement with aquaporin 4 positive disease. We contrast this here with MOGAD, which is showing here bilateral optic nerve involvement and more involvement of the anterior optic nerve, whereas here's an example of MS, a short segment lesion sort of in the middle portion of the nerve. So the optic nerve pattern involvement can help distinguish these diseases. So during an attack, MOGAD is more often bilateral. It affects the anterior portion of the optic nerve and often causes optic disc swelling. As you'll appreciate on MRI scans, it sometimes also shows, as outlined here in this schematic, involvement of the optic nerve sheath, so beyond the optic nerve itself. Gadolinium enhancement of the chiasm is characteristic of aquaporin 4 positive NMOSD, and then a much smaller and sort of more benign lesion in multiple sclerosis. Follow-up MRIs typically show that this enhancement will resolve in all disorders. What about myelitis and MOGAD? Well, myelitis can be isolated, or it can be associated with optic neuritis or an acute disseminated encephalomyelitis-like picture, ADEM-like picture, again, often in children. Myelitis can be severe, but like the optic neuritis, can have good spontaneous recovery in many patients, although some are left because of lower cord involvement, it seems, with bowel or bladder impairment or erectile dysfunction in men. The presentation can mimic an acute flaccid myelitis. And interestingly and important to know, the MRI scan is typically normal in about 10% of patients. So that means you need a good examination and high clinical suspicion for the possibility of an inflammatory process. And you'd want to repeat the MRI in, say, a week to 10 days to see if you can now detect the emerging lesion. Just like with the optic nerve, the patterns of involvement with MOGAD differ somewhat from those of MS and aquaporin 4 positive disease. These MRIs here are showing this sagittal line on sagittal T2 imaging within the cord, but axial imaging shows what's called the H sign because of involvement of the central gray. And that is probably the most distinctive feature of MOGAD-associated myelitis. Here's another example of close-up example of the H sign and this sort of non-specific linear pencil-like lesion, often non-enhancing, even in the acute stage in the spinal cord with MOGAD. And again, in comparison, you have the expansile and diffusely enhancing lesion here associated with aquaporin 4, central cord involvement. Note how distinct these disorders appear. Of course, there's going to be some patients who have overlap or in whom it's not going to be clear. But again, here's a patient with MS, dorsal lesion, short segment, ring enhancing or somewhat ring enhancing, and occupying only a portion of the peripheral cord. So looking at the films, you may be able to glean this from a radiology report if a neuroradiologist who has this knowledge base can distinguish between these, but this is a major advantage of being able to look at one's own films. So again, to recap the myelitis patterns in MOGAD during an attack, the H sign, the lower cord more likely involved, but it can be any region of the cord. The aquaporin 4 disease, longitudinally extensive and central, in contrast to the MRI scans. Note also what happens on follow-up. The spontaneous clinical resolution is accompanied sometimes by disappearance of all of the lesions in the spinal cord in MOGAD. That's actually quite rare for aquaporin 4, which is destructive, typically destructive in all regions of the CNS, except perhaps the dorsal medulla. And even in multiple sclerosis, which has milder attacks than aquaporin 4 positive disease, usually leaves footprints within the spinal cord, but MOGAD may not. So if a patient has had a prior spinal cord attack and a prior MRI, it's good to get a hold of those original images and scrutinize them carefully because a follow-up MRI scan now is likely to be normal. This slide just summarizes the differences between these three diseases. Again, these are the big three sort of competing diseases that we would see most commonly in patients who have this type of CNS autoimmunity. Aquaporin 4 positive disease is rare, and the target cell is the astrocyte. MOGAD is somewhat more common, especially in children. The target there is the oligodendrocyte. That's where MOG is living. And we don't know what the target antigen or cell localization is for multiple sclerosis, which is the most common of these diseases. Some of the other features to know are that the antibody-associated disorders like NMOSD and MOGAD typically do not develop a progressive clinical phase. So someone who has a history of relapses but is now reporting that they have a decline, for example, in their walking over the last couple of years is more likely to have MS than these other disorders. It's not impossible to have progressive disease, especially with NMOSD, but the incidence seems to be as low as 2%, whereas most patients with MS, especially if untreated, will develop progressive disease. So that's an important clinical clue as well. What are some of the pearls and pitfalls with making these diagnoses? Well, first of all, there's no clinical manifestation that establishes a diagnosis of NMOSD or indeed MOGAD or MS. So we rely a lot on the clinical picture together with MR imaging and understanding those patterns. So it's a lot of pattern recognition. And then, of course, the antibody testing. And so in the case of aquaporin 4 and MOGAD, we really like to see the antibody be convincingly positive in the right clinical context in order to make the diagnosis. For aquaporin 4 disease, you test in serum, and ideally you order an assay that is a live cell-based assay, or CBA. That's the current reference or gold standard. There are other assays like fixed CBA or ELISA, which are somewhat less sensitive. In the right clinical context, they're still useful, but if there's concern about an atypical diagnosis or an uncertain antibody result, the live CBA is the test you need. People often ask about CSF testing, but CSF is rarely positive for aquaporin 4. And even then, when it's positive, it's only when the serum level is very high. So there's little to no utility in testing CSF specifically for that reason only. One needs to be thoughtful when interpreting the serology. So false positives can occur with ELISA assays, the less specific assays at low titer. Always need to take into account the clinical presentation. That's true with any diagnostic test, but especially these assays. Confirmation with the CBA if there's uncertainty. Test for MOG in patients who are AQP4 positive negative, AQP4 antibody negative, I should say. And then retesting so-called double seronegative cases is a wise thing to do, because sometimes initial testing that's negative will later become positive. Now, to change gears for a moment, I mentioned near the outset that we have criteria for NMOSD that's stratified by the antibody. So you can have seropositive or seronegative disease. So what are the criteria for aquaporin 4 IgG seronegative NMOSD? Well, here we don't have the specificity of the antibody to leverage. So the diagnostic criteria gain specificity through other means. First, they do it by requiring that the clinical disease affect 2 or more regions of those 6 neuroanatomic regions I mentioned earlier. Remember that for seropositive patients, they only need 1 region affected. So optic neuritis plus a convincingly positive aquaporin 4 antibody equals seropositive NMOSD. But for seronegative disease, you need at least 2 regions. So you would have to have optic neuritis and myelitis. Now, that could be one attack, or it could be multiple sequential attacks, but both have to be there. You could get involvement of other regions, but because the optic nerve, the spinal cord, and the area postrema are the most commonly affected in seropositive disease, and that's how the seronegative construct was developed, you require optic neuritis, transverse myelitis with a longitudinally extensive lesion, or area postrema, of course, with MRI lesions, to make sure that we are excluding competing diagnoses, especially multiple sclerosis. What do these patients really have? Do they truly have NMOSD, and for some reason we just are not detecting the antibody? That might be true in some patients. Retesting, as I mentioned, occasionally will uncover a truly seropositive patient. But many of these patients initially seem to have MOGAD. When the current diagnostic criteria for NMOSD were published in 2015, MOGAD was just emerging as a concept and had not really been validated. But now we know that many of these patients, especially those with optic nerve and spinal cord involvement only, are aquaporin 4 negative, but convincingly MOG positive. We believe they have this condition, MOGAD. The rest of these patients seem to be quite a heterogeneous group. They're a mix probably of conditions that appear to mimic opticospinal phenotypes in various ways, and maybe some idiopathic syndromes. But the reality is that the literature is quite mixed, and we really don't know what these seronegative patients are or whether they represent multiple disorders. This is a good reason why we need to be particularly careful about reaching a conclusion that a patient has NMOSD without the antibody, because there are so many potential competing diagnoses. Some red flags to consider: I mentioned earlier, a progressive clinical course is generally not compatible with NMOSD. Similarly, a very rapid onset of an acute attack, something occurring from onset to nadir within 4 hours, would also be atypical and would suggest something, for example, like a cord infarct. And a slowly and continually progressive disorder, a relapse, if you will, or an attack that seems to be continually worsening over many weeks, we would consider other disorders such as granulomatous disease, sarcoidosis, or even a neoplasm. Some patients with NMOSD do have some brain lesions. I showed you some of the so-called signature patterns before, but some patients will just accrue nonspecific lesions in the brain. But if you see Dawson's fingers or involvement of the juxtacortical regions in the brain or the inferior temporal lobe, be cautious that you might actually be dealing with MS. And of course, the short segment lesions in the peripheral spinal cord would be a clue as well. Complete resolution of lesions should suggest MOGAD, and persistent MRI lesion enhancement of greater than 3 months is also a red flag. In particular, we'd be thinking about things like, again, sarcoidosis. CSF oligoclonal bands are more common in MS than these other conditions, though not specific. And then some patients will have comorbidities, so they'll actually have multiple disorders, or they'll have a presentation of an opticospinal syndrome that seems to be associated with cancer, a chronic infection such as HIV or syphilis, or the great modern mimicker of sarcoidosis. So here's another illustrative case vignette 4, a 54-year-old man who presented for a second opinion regarding LETM. He had 3 months of progressive walking difficulties and needed to use a walker. His CSF showed a high protein, oligoclonal bands, and a significant pleocytosis with 148 nucleated cells. He was treated with IV methylprednisolone and some initial improvement, but he continued to worsen. You can see his MRI scan here shows what appears to be an enhancing, longitudinally extensive lesion of some type in the thoracic cord. 6 months later, he was needing a wheelchair, constipated, had neurogenic bladder dysfunction as well, and really quite a severe paraparesis with upper motor neuron findings and long-tract sensory impairment. So this is his MRI scan, and I'm showing you here the extension of that thoracic lesion throughout almost the full extent of the cord, along with gadolinium enhancement across multiple segments, but especially of the dorsal cord. And if you look in cross-section, this patient has a lesion that's enhancing kind of all around the periphery of the dorsal and dorsolateral cord, and with entry into the dorsal aspect of the cord here. And we call this a appearance of a trident, and this is the trident sign in this disease. So the red flags here were a slowly progressive course, persistent enhancement, and indeed worsening of both T2 signal abnormality and enhancement over more than 3 months. This patient turned out to have sarcoidosis. PET-CT showed mediastinal lymphadenopathy, which was biopsied. He had non-necrotizing granulomas, which confirmed the disease. We would technically call this probable neurosarcoidosis because he didn't have a CNS biopsy, but certainly his clinical course fit very well with sarcoidosis. And that trident sign, which I show here again, perhaps is not pathognomonic, but is really very suggestive of sarcoid. Here's another case, a 32-year-old man who is otherwise healthy. He presented with bilateral blurred vision, painless, and he was found to have papilledema, or as one ophthalmologist called it, bilateral papillitis. He had an increased opening pressure on CSF exam, 44 centimeters of water. His protein was a bit elevated, but otherwise his spinal fluid was normal. And he was thought to have probable idiopathic intracranial hypertension based on this examination and the fact that his brain MRI appeared normal. He started on medical management, which didn't do anything, and so he got shunted for this diagnosis. 2 months later, he presented with truncal and bilateral leg sensory symptoms, and then he became weak in his legs and he couldn't ambulate 6 weeks later. Because of his paraparesis and his optic nerve dysfunction or visual dysfunction, he was thought to possibly have NMO and referred for that question. On exam, he had a BMI of just over 26, so he was perhaps in the slight overweight range, but not obese, as you might see in most patients with IIH. He had very impaired visual acuity in his right eye with disc pallor and an RAPD, but also quite prominent disc swelling or papilledema. He had an asymmetric spastic paraparesis and a sensory level. His spinal cord MRI at this point showed a lesion involving multiple segments of the spinal cord, and it looks quite expansile, but it also looks like it's sort of filling the canal and looks quite homogeneous on this non-enhanced scan. And this is his axial imaging showing, basically confirming that it looks like he's got something infiltrative within the cord that is expanding and essentially filling the spinal canal. This was ultimately biopsied. He had a grade 3 fibrillary astrocytoma, and unfortunately he progressed to paraplegia and ultimately died of this disease. But his evolving spinal cord mass seemed to be associated with papilledema in the absence of hydrocephalus. We don't know the exact mechanism of this, probably some type of CSF flow abnormality related to his expansile cord lesion, but this patient was thought perhaps to have NMO on the basis of his clinical presentation, negative brain MRI, and what superficially looked like a long lesion in his spinal cord. But the ultimate answer, the final answer, was a neoplasm. So there are some more common potential NMOSD mimics for visual loss, especially in people above age 50. Optic neuritis is possible, but so is ischemic optic neuropathy. That may or may not be arteritic in nature, but mistaking an ischemic optic neuropathy for an inflammatory one is fairly common and, to be honest, quite challenging, I understand, even for experienced ophthalmologists. Primary ocular disease can sometimes mimic optic neuritis, and myelopathy can also commonly be caused by compressive spine disease. So discs or spinal stenosis in the cervical cord can sometimes cause lesions that can mimic inflammation. And then you can have pathology that affects both the eye and the spinal cord, things like vitamin B12 deficiency, which is common generally, and a common comorbidity with NMOSD, and even disorders like CIDP can be associated with CNS and optic nerve involvement. So we come back to the criteria for the seronegative patients, just to remind you what these look like, and point out that you're identifying with these criteria a syndrome. You don't have a specific biomarker like aquaporin 4 to help confirm the disease. But I would add to MS and MOGAD a whole variety of syndromes, as I showed with the series of vignettes, that can mimic especially opticospinal disease. It's important to keep that in mind. Thus, seronegative NMOSD needs to be a diagnosis of exclusion. This is an algorithm that I think is quite nice in proposing an approach to diagnosis of NMOSD, beginning, of course, with history, the clinical presentation, and physical examination. And if that gives one reason to think about NMOSD as a possibility, then you see on the left side here, testing for aquaporin 4 with the CBA. And if that's negative, the authors here, this was from a consensus group in Germany, proposed testing for MOG-IgG, In reality, at least in the United States, most of the time these antibodies are tested together. In parallel with this, we do general laboratory testing, imaging of the brain, orbits, spinal cord, maybe OCT if the issue is involving the optic nerves, and in many cases, a CSF analysis. One would look for red flags in the clinical history and in the test results, check for alternative or coexisting diagnoses, and then determine whether the criteria for NMOSD are met. In patients who are seropositive for aquaporin 4, you may not find an alternative, better explanation, but you might find some coexisting autoimmunity or additional diagnoses. So it's still important to keep that in mind. And then, as pointed out here, retesting might be useful in some patients with initially negative results. So what's next in this field? Well, there will be, in the not too distant future, revisions to the diagnostic criteria for NMOSD. Why? Well, the current criteria are now 10 years old. As I mentioned earlier, MOGAD has emerged as a real and validated condition with its own set of diagnostic criteria that separate it from aquaporin 4 positive disease and MS. There have also been a lot of advances in technology, the specificity and reproducibility of aquaporin 4 assays, as well as imaging patterns and biomarker science that is added to our knowledge about NMOSD. And perhaps most importantly, the need to readdress the so-called double seronegative cases. So those cases that are both aquaporin 4 and MOG antibody negative, and who, despite extensive evaluation, don't have another diagnosis and are called seronegative NMOSD. So there's a group convened and supported with assistance of the Guthy-Jackson Charitable Foundation to revise these diagnostic criteria. Essentially, what they'll do is refresh the seropositive criteria and readdress the concept of seronegative disease, both for clinical and research purposes. So we look forward to that. In this slide deck, there's a couple of additional resources to assist you. This is a summary of key differential diagnosis, which is expanded a little bit beyond what I've been able to go through today with my case vignettes. But you see at the top panels listing potential competing diagnoses under the umbrellas of inflammatory or infectious diseases, and then also neoplastic, vascular, metabolic, genetic, and other disorders. So a systematic approach to each of these categories may be necessary, most especially in patients who have an opticospinal syndrome, but who are aquaporin 4 and MOG negative. This kind of rubric, I think, helps remind people of other competing diagnoses, especially when they are rare. This slide is another hopefully helpful summary, a pocket guide to differential diagnosis, which lists select diagnoses or groups of diagnoses and some clues that would help you think about the possibility of these competing diagnoses when faced with an individual patient. So listing here the pearls, the symptoms and signs that might be characteristic of or highly associated with specific types of disorders, biomarkers, MRI, and other factors. So for example, as I mentioned earlier, multiple sclerosis, characteristically mild to moderate attacks with good recovery. An internuclear ophthalmoparesis in a young patient is almost always going to be MS. A progressive clinical course, the CSF biomarkers, the MRI features, and then noting here upcoming McDonald criteria revisions for that diagnosis. And this pocket guide is a quick reference for some of the key features of other diagnoses like MOGAD, anti-GFAP disease. Note that this is a astrocytopathy that is associated with antibodies against GFAP. So this is different than GFAP as a biomarker for NMOSD. This is actually where the antibody targets this protein, and this has very characteristic clinical imaging and CSF presentations. And in fact, the antibody is best detected in the spinal fluid. And then characteristics of disorders you don't want to miss, like neurosarcoidosis, specific infections, cancers, paraneoplastic disease, para-infectious or vaccinal associations with NMOSD, which are really a diagnosis of exclusion, and occasionally metabolic or genetic disorders. This is an additional resource for which an interactive version will be made available from the Guthy-Jackson Charitable Foundation. So in summary, hopefully I've presented some convincing data to show that NMOSD has a broad clinical and radiologic spectrum that ultimately has been anchored by or defined by serum aquaporin 4 antibody detection in affected patients. The antibody is quite specific, but one needs to think about ordering the antibody in the right context and then interpreting it properly and knowing what to do if the antibody is negative. So clinical clues and MRI signatures are diagnostically very useful, both in thinking not only about NMOSD, but its competing diagnoses. The serum aquaporin 4 IgG live CBA remains the reference standard if one can obtain that. And so-called double seronegative NMOSD remains a vexing and heterogeneous diagnosis, which requires on an individual basis extra care in examining the differential diagnosis and testing for alternative diseases, but also requires a fresh approach to diagnostic criteria, many of us believe. So with that, I'll close. I thank you for your attention and hope that some of this was helpful as you see patients affected by these disorders.
Dean, thank you so much for that excellent review. Very insightful, very practical, and filled with clinical pearls. We do have a few questions, Dean. We could possibly ask you to provide brief comments. The first, can clinicians confidently use aquaporin 4 IgG assays other than the live cell-based assay as a gold standard?
Thanks, Michael. Yes, that's a common question. Partly it's common because aquaporin 4 testing access remains an issue worldwide. So in the United States, we're fortunate most of the time to be able to access some type of aquaporin 4 testing through various laboratories. And this is also true in places like Canada, many areas of Europe, Asia, and South America, but it's certainly not universal. But even when someone can access the aquaporin 4 assay, it might be an ELISA assay, for example. Those assays are somewhat less specific and less sensitive. And the challenge often comes in where you have a patient that really looks very consistent with NMOSD, but has a negative ELISA. That's an instance where you would want to get the live CBA if at all possible. Another concern with the ELISA is that sometimes it'll come back as a low titer. And just by definition, by its methodology, ELISA is a less specific method for detection. And so sometimes we see patients who really look like they have very typical multiple sclerosis. They have a low titer aquaporin 4 ELISA assay result. And we simply don't think it fits together. And so we'll get a CBA, a live CBA, and it typically is negative and helps us confirm that, in fact, it's MS. On the other hand, if somebody has a very typical clinical presentation, let's say a longitudinal spinal cord lesion, and they've had optic neuritis, and an ELISA is positive at a convincing titer, at a high titer, it's probably the right answer. So I think, yes, one can just use what's available, the best available test, and recognizing that that always can't be a live CBA, In many situations, other assays will suffice.
Thanks, Dean. That's very helpful. Another question pertains to what is the significance of a progressive clinical course, for example, chronic progressive myelopathy?
Yeah, well, I alluded to this earlier in the presentation about progressive clinical course being a red flag against a diagnosis of aquaporin 4 positive NMOSD. First of all, I think it depends on how long the problem has been progressive. So I gave the example of a few months of progression, continual progression, which was really atypical for a relapse of NMOSD, and that patient turned out to have sarcoid, which would characteristically be a smoldering and slowly worsening over months process. But also, patients sometimes have a chronic and progressive myelopathy occurring over years. So they'll report that they're losing ground with their walking ability year by year. That's the type of clinical course that would be more convincing of something like secondary progressive multiple sclerosis, or, of course, other causes of chronic progressive myelopathy. But it's quite rare in aquaporin 4 positive NMOSD. In studies that we did at Mayo Clinic, the occurrence of a convincing secondary progressive course in aquaporin 4 positive disease that we didn't have another explanation for was only 2%. So can it happen in NMOSD? I suppose it can, yes, but it is a red flag. It's something that makes us think about an alternative diagnosis.
Thank you, Dean. Can MS and NMOSD coexist?
Yes, another common question. And I think a challenging one because the clinical and the imaging and CSF features of the two diseases overlap. And sometimes there are situations where it can be quite difficult to know whether, is this a longitudinally extensive lesion or not? It's not quite 3 segments. These lesions in the brain are not entirely typical for MS, or you have a patient that seems to have both of those features. I would say statistically, anything is possible. You would have a patient unfortunate enough to have both MS with an incidence of about 1 in, say, 700 in the general population in the United States, maybe even more common than that. NMOSD being quite rare, just based on statistics, I suppose it could happen. There's no immunopathologic or biological link that we know of between the two disorders, so they're not necessarily connected, meaning, at least my current thought is that if they coexist, they probably do so by chance, or maybe just by appearance, but not necessarily by biology. There have been cases, I know of one case report quite recently, where the contention of the authors was that indeed a patient presented with lots of evidence to support MS, and then had a longitudinally extensive myelitis event and was convincingly positive for aquaporin 4 antibodies, and they believe this patient probably did have 2 pathologies. But that would certainly be exceptional.
Very interesting. Another question, Dean. A patient with recurring optic neuritis and longitudinally extensive transverse myelitis, a normal brain MRI is seronegative for aquaporin 4 and MOG antibodies, and the other workup is negative. Should that patient be retested for antibodies? And if so, when might that be best?
Yeah, thank you. So I touched on some points related to this question earlier and indicated that retesting could be helpful. I think retesting for aquaporin 4 antibodies is definitely important if initial tests are negative and they weren't done with the best available assay. So trying to get, if one did an ELISA, trying to get a cell-based assay, ideally live CBA if possible. That's one scenario. Another would be if a patient, let's say they presented with that longitudinally extensive myelitis and had been treated with steroids and plasma exchange, And during that treatment or shortly after, their blood was drawn for aquaporin 4 antibodies. Well, the plasma exchange and maybe even the prednisone or the IV methylprednisolone might have rendered the antibody undetectable. So waiting for the effects of those interventions to wear off and then retesting would be quite reasonable. And then finally, I would say another opportunity for retesting would be at the time of a new attack. So there are some data to suggest that around the time of an attack, there may be somewhat higher titer of aquaporin 4 antibody in the blood, so you have a better chance of detection. I do think that in somebody who has a compelling clinical and radiologic phenotype, that just simply retesting, a few months after the initial presentation may be worthwhile, but it does appear that that conversion rate, if you will, not detecting it initially and then later detecting it on routine testing, it doesn't turn up a positive result very often. When it does, it's probably more to do with technical issues related to the assay itself rather than, say, the patient truly seroconverting. At least that's the current belief.
Thank you very much, Dean. Just a question or two more. One, should a clinician look for underlying cancer in patients with NMOSD with antibody positive aquaporin 4 IgG?
Yeah, great question. In most cases, probably not. It would appear that fewer than 5% of patients in this scenario would have an important occult malignancy, one that is that one would think might be linked to the neurologic presentation. However, I think if you had a patient with risk factors like a long history of smoking and that patient was older and had a particularly severe attack or course or poor response to treatment, those would be things that would make me look harder for an underlying malignancy. But routinely, we generally don't do the type of whole body workup for an underlying malignancy that we might in other CNS autoimmune disorders.
And then lastly, Dean, how extensively should I be looking for coexisting autoimmune conditions in patients with NMOSD or related conditions?
Yeah, this is an interesting question because I think the more you look, the more you're likely to find. But a lot of what's found may not necessarily be actionable. So, in other words, it's common to see a patient with NMOSD who has a positive ANA antibody at a moderate titer and maybe a positive SSA antibody, but they don't have any symptoms related to that. And over follow-up over years, they don't seem to develop any. But my own practice is to test for a few things that are actionable. I will check for B12 in all patients because of the frequency of pernicious anemia, and that's a treatable condition. In some cases, might even be contributing to their neurological problem. I also routinely check for thyroid disorders for the same reason, common and treatable. In patients who I am investigating for NMOSD and who are aquaporin 4 negative, especially in MOG negative, I usually have also gotten a fairly extensive panel of autoantibodies on them because I'm essentially looking for that pattern of coexisting systemic autoimmunity. Before we had the aquaporin 4 antibody, we used that as a kind of a proxy or a marker that the patient had humoral autoimmunity and that was distinct from what we typically saw in multiple sclerosis. So in other words, some of these double seronegative patients will have, multiple positive autoantibodies. And then that just tells me, it just gives me some maybe checking a small checkbox that yes, they've got an autoimmune condition. Maybe we can't characterize it yet, but hopefully they'll still respond to, longer term immunosuppression. So I hope that helps.
Great answers, Dean. Thank you so much. Dr. Dean Wingerchuk, Chair of Neurology, Mayo Clinic, Scottsdale. We really appreciate your excellent review and all your insights and pearls, Dean. Thank you.
My pleasure. Thanks for the opportunity, Michael.
Well, as a follow-up to that outstanding presentation, we do want to remind you that there is CME credit available. The process is to visit the GJCF Education Center using the QR code shown here. You can select this session and register for credit, view the session and fulfill the viewing requirements, and then receive CME certification online. We also would like to remind you of the outstanding lineup of presenters who will be upcoming in the NMOSD Grand Rounds series. So please check the Education Center website using the QR code shown in the lower left. The GJCF Education Center is a new resource that we hope you find helpful. It includes the NMOSD Grand Rounds series, as well as information regarding educational events other than the Grand Rounds, and a number of other presentations and multimedia resources that might be helpful to you. You can see the link information, or again, use the QR code shown in the lower right. We want to thank our industry partner, Alexion, the AstraZeneca Division of Rare Disease, for their support for the NMOSD Grand Rounds sessions.